This is our faith that I go back to the South with. With this faith, we will be able to hew out of the mountain of despair a stone of hope. With this faith, we will be able to transform the dangling discords of our nation into a beautiful symphony of brotherhood. So as we relate this latter thought to the issues of healthcare disparity, my question that I pose to myself and to each of us, are we there yet? If we accept the root cause as one that results, as Brandon opened up with, that the healthcare disparities are rooted in historical experiences of opposition and exclusion, both of which disproportionately affect not only people of color, but women as well. It would be too easy to throw up our hands and say, I'm sorry, there's nothing that I can do. It's just the way it is. However, we're not going to take that approach of defeat today or take that stance that nothing that we can do to make a real dent in this societal injustice. But I like the childhood riddle that adds a lot of color commentary to the issue of healthcare disparities. And it's the childhood riddle that says the best way to eat an elephant is one bite at a time. And that's the same charge that I would render of how we approach healthcare disparities. The definition set forth for healthcare disparities in the Minority Health and Health Disparities Research and Education Act of 2000 is the following. A population is a health disparity population if there is a significant disparity in the overall rate of disease, incidence, prevalence, morbidity, mortality, or survival rates in that population as compared to the health status of the general population. In other words, health disparity is not a result of access. Health disparity is not related to factors of clinical need or patient preference or the appropriateness of the intervention. Disparities are well beyond access. So to answer the question that I posed earlier of Dr. King's charge, the ability to transform the jangling discords of our nation, obviously the answer is a clear and resounding no. We are definitely not there yet. When we consider the overwhelming evidence outlined in the Institute of Medicine's consensus report of 2002 called Unequal Treatment, this report found a consistent body of literature. So I'm not talking about one or two reports, but a consistent, compelling body of literature that suggests that even when we account for insurance status, for race, for age, for income, for age, for insurance status, and severity of conditions, the U.S. racial and ethnic minorities are still less likely to receive routine medical procedures and receive lower quality of care than majority populations. And to the contrary, it's also true that they are more likely to have undesirable procedures done, like amputation of lower extremities associated with diabetes and other conditions. So they can't get the help and the interventions that are commonly available, but all too often get the negative consequences that result in some type of amputation. So certainly these data bespeak of a higher level of complexity, how most of us think about disparities. Most of us think about it being an issue of access. But it is not simple by any stretch of the imagination. Disparities in healthcare is multifactorial, and I would segment 3 different areas of health disparities for you today to help clarify all the different factors in my mind and realms of healthcare disparities. 3 separate and distinct domains. The first one, even though it's not about it purely, is access. And that is foundational. We have to talk about access as a starting point, but it doesn't end there, nor is that the sweet spot, as we describe it, for interventions by industry. Access takes into consideration issues like poverty and other social determinants, like having healthy fruits and vegetables available in certain grocery stores in certain communities. Access also bespeaks to the fact of a willingness or the lack thereof of being able to take a walk for exercise because of fear of safety in certain neighborhoods in our United States. This is the focus of most federal programs in socialized medicine, where industries do what we can through foundations and grants, and oftentimes make multi-million-dollar grants and contributions to eradicate poverty and diseases. You will oftentimes read about both pharma and device companies banding together to make therapies available in countries or places to people who couldn't otherwise afford them, and particularly around the world in areas of infectious disease, most commonly, such as malaria, HIV, and AIDS, etc. The second domain of healthcare disparities is therapeutic delivery and quality of care. Now, this is the ultimate sweet spot where healthcare manufacturers can and are in a unique position, particularly, to leverage the skills and the resources that we have available to us to make a noteworthy contribution. And this includes addressing all key stakeholders involved in healthcare disparities. We take an approach where we can touch not only the patient, we can impact the physicians, we can impact healthcare systems at large, and certainly we're in a position to impact payers. That all said, we have the ability to deliver, alone or in partnership with other institutions, culturally competent patient education materials such that it facilitates a robust and thorough dialogue between the healthcare provider and the patient themselves. The third domain that I'd like to take a few moments to speak to is outcomes. Now, oftentimes this domain is spoken about in the context of targeted therapeutics, or what we call personalized medicines. This suggests that clinical outcomes can be improved with the delivery of treatments based upon genetic disposition. Stated another way, it presumes that genetically appropriate treatments can optimize clinical outcomes in individuals and or homogeneous patient subpopulation. This approach necessitates that manufacturers such as mine and those in the pharmaceutical industry from which I came are willing to pay the incremental amounts associated with clinical trials that are powered large enough to be able to do subpopulation analysis, to be able to identify opportunities within these subpopulations, and to be able to show statistically significant improvement in outcomes relative to other populations in the areas of age, race, and ethnic origin, etc. I will also note here that this targeted therapeutic approach is laden with controversy and has a fair amount of critics who argue that these practices are discriminatory. So then it is in direct opposition from the goal that it's created to serve, because and it poses a catch-22 to manufacturers, and I'll give you an example to illustrate that point. Take, for example, Bideal. Bideal is manufactured by a small company called Nitromed, and it conducted its pivotal study in a population of about 1,050 African Americans. The goal of the study was to show the reduction in heart failure and morbidity in African American patient populations. And indeed, the study did show a 43% reduction in risk of death in this population. The evidence was so overwhelming and compelling, in fact, that the DSMB, which is the Data Safety Monitoring Board, which is an independent group of physicians who monitors the safety of clinical trials, halted the study in July 2004 to encourage Nitromed to seek approval by the FDA of the drug targeted at African Americans with these strong outcomes. However, upon launch in the summer of 2005, Nitromed was surprised by media headlines. This was a perfect case study. They were shocked by the media headlines, and I actually did a Google search to find some of the headlines that came out at the time. Here are two: casting doubts on race-based medicine, and the second is race a proxy for care. There was so much scrutiny that the first full year of sales, only 84,000 of the 750,000 African Americans who were candidates for Bideal actually had received a prescription for its care. Now I'd like to contrast that with the statin market and statin sales during that exact same period of time. Statins are lipid-lowering agents or anti-cholesterol agents and sold under brand names like Lipitor and Zocor and Crestor, etc.